and Mayor Pro Tem. I'm Jason Balling, and here to provide another update on where we're at with the latest COVID information. Joining me today is Deb and Sarah, but we also have Dr. Chris Urbina, our medical officer, and Helene Lanzer, our manager of community nursing. And we really wanted this to be a deeper dive because we know there's a lot of questions out there, both from council and our residents around as we move into this new phase of level clear and those with vaccination status and those that may not be. What does it mean for immunity and potential risk? And at the same time, we've received questions in these previous sessions around if you've been previously contracted COVID, what does that mean as far as level of immunity? So we wanted to make sure we left enough time at the end of this presentation to answer those questions. And thankfully, they're definitely two of the experts that we have. I do want to start out with some extremely good news that just came across my phone. The FDA has authorized the use of the Pfizer vaccine for children 12 to 15. So that's wonderful news, exactly, for our next group of residents that we know need to get vaccinated. And with that, we'll go into the details of what it means as far as next steps with the Advisory Committee of Immunization Practices. So if you could go to the next slide, Sarah. Yeah, what we're starting to see is as far as case rates, and we'll get into this a little bit later, both at the state level and here in Broomfield, we're starting to see some impact, I believe, of vaccinations with other factors on our case rates. So you can see that we've had 69 additional cases this week. Thankfully, no hospitalizations or deaths, and our 1 week positivity has dipped down below 5% again, which is great news. Next slide. And again, this is just that measure that we'll be tracking as we move into level clear after May 16th. If we ever had to snap back as far as due to hospitalizations, but what you can see right now is everything's trending obviously in the right direction. Next slide. So not much to update on the statewide Epi Trends. As I was mentioning before, we're sort of in this period where last week when we updated this slide deck, the cases and percent positivity were relatively flat at the state. We're seeing those decrease this week. We'll see if that becomes a trend. Again, the growth in hospitalizations and infections appear to be largely due to those that are contracting that are younger than 65. And I think we're starting to see that move even further down in those age groups because we're vaccinating those 50 to 65-year-olds. About 41% of Coloradans are currently immune. And then as far as the variants, we talked about this briefly last week, but they've identified cases of the B.1.617 variant last week in Mesa County, and they're tracking that. This is one of those variants where we're still gathering information on it. And I understand there's multiple variations of the variant that Dr. Urbina might be able to address. So I would say there's more information we have to learn about this specific variant and what it means for us as we move forward. Next slide. So here in Broomfield, we are seeing a sustained decline in incidence of cases. And again, we can hypothesize what's playing into this. What the state has been analyzing and really tracking is as you see vaccine status go up in a county, you start to see case rates go down. And I believe that's what we're starting to see happen here specifically in Broomfield, which is good news. We've talked about being dropping back below that 5% positivity rate. And then we just have to continue to monitor those populations, specifically the 10 to 19-year-olds who some of those, as we mentioned before, didn't have access to the vaccine, and others, the 16 to 19, were eligible through the Pfizer vaccine, and see what that means. And then our 20 to 29-year-olds are a group that we know that we need to continue to outreach to, but we're seeing continued high cases in that age range. We continue to lead the metro area as far as vaccine uptake. You can see 73% of Broomfield's eligible population have initiated or completed the vaccine. And again, what we're seeing is great news. Those people that start to initiate are actually following through with completing their vaccine. So 60% have completed, and we've had 13% initiate. And I looked at our vaccine graph, and we're still seeing that initiation graph go up. We're not seeing it level off yet, which is good news. So hopefully that continues. And then you can see the various variants that are circulating in Broomfield. And again, we estimate the B117 is the most prevalent one, both in the state and here in Broomfield County. The next slide. So with that, I'm going to turn it over to Deb to dive into where we're at with vaccines, and then she'll turn it over to Dr. Urbina.
Yep, thanks, Jason. So like Jason shared at the front end of the presentation, that we have good news to share with moving towards being able to vaccinate our 12 to 15-year-old population. And so the Advisory Committee on Immunization Practices, it's a committee of the CDC, meets on Wednesday. And then following that meeting, we will have the recommendations and details for those of us that are going to be involved in administering the vaccine. So we will be working with our local partners, our pharmacies, coordinating with our schools and other ways to connect in with families that have children of that age to alert them of opportunities in the days and weeks ahead. So it's great news in terms of our vaccination efforts. And you can see there on the graph on the right, we've really, Broomfield has continued to really have strong participation in vaccination efforts amongst residents in our communities across age groups, with reaching close 75% or greater with anyone age 40 and older that is eligible for the vaccine here in Broomfield, which is exciting. So now we really are focusing on those younger populations, now starting at 12 through 29-year-olds. One of the things that we are experiencing is that, because we have such high participation rates in vaccination to date, the percentage of the eligible population who wants the vaccine and hasn't gotten it yet is shrinking. And so as we've shared in previous weeks, we're moving away from that model of large scale mass vaccination events and really focused on much more targeted efforts. And one of the things that we are doing is continuing to work closely with our community partners, including those vaccine ambassadors who are currently surveying their networks and residents in the communities to understand if people are waiting for the vaccine, to try to dig into that a little bit more, understand the why, and ask questions such as what would prompt you, what would make you more likely to get the vaccine, and just really trying to understand. Certainly we have state and national data on that, but it'll be interesting just to hear directly from our residents so that we can continue to provide information that people need and to target efforts in the weeks and months to come in response to that. So a much more focused, resource and intensive effort at this point, moving away from those mass vaccination events. But again, in the weeks ahead, our focus will be on that younger population. And the good news is there is sufficient capacity here in Broomfield amongst vaccine providers. People are able to make appointments if they want them. And then we're also really trying to also share information related to where if you don't have an appointment, if you have the opportunity to still walk in and receive a vaccine, where can you do that? Because that is also an important piece of information. So I think with that, I am going to hand it over to Dr. Bina. At the last meeting, we started to get into the conversation about as we move away from public health orders and as our vaccination rates continue to climb, really being in that place of individuals assessing risk, and had some good discussion last time and questions related to what is the risk of reinfection. So with that, I'm going to hand it to you, Dr. Bina, just to talk a little bit about it.
Thank you, Deb, and thank you, Jason. Sarah, I have a little black bar on the slide on the right where it covers up the words. Is everybody else seeing that, or is that just me?
Yeah, no, I was wondering if that was just my screen, but it's
No,
there.
I just noticed it too, like moving around.
I think it's you guys. It's like your little panel of you all. Let me see what I can do to move you around.
I was like, is my screen going out? Right? That was
Is that better?
Yes, much better. Thank you.
Sorry.
I thought this was a dementia challenge here. I was trying to read through the black box. So thank you for, I'm glad you're not alone, Pro Tem, Mayor Pro Tem. Okay, so I know this is a little bit busy slide, but let me give you the high level pieces of it. You can see by the dots here that your overall rate, the more you're vaccinated, the less likely you are to get the infection. So it's a very clear correlation, and maybe next week we'll share with you some of the slides about where you see clear deviations. As you increase the vaccination rates, your cases go in the opposite direction. It's a very clear correlation, and the full vaccination, as you see, corresponds to approximately 92% protection against being reported as a case in Colorado. If you remember, the clinical trials said in that 70,000 plus people who took both the Pfizer and Moderna vaccines that they had a 94 and 95% effectiveness. Well, it turns out now in the real world, they went back and looked at many of those first responders, healthcare workers, and people who got that first dose of vaccine and followed them for months. And it turns out that it is true in the real world that over 90% of people who got the vaccine didn't get the infection. Earlier, we had only been able to talk about reducing hospitalizations, severe illness, and death. Now we know in a real world setting that over 90% effective. And if you get one dose, it's anywhere between 60 and 80%. If you look at the studies, it depends on the population, depends on their abilities to mount immune responses. That's still being studied. And so it's likely to be higher than that, but we can only report to you a range of effectiveness after one dose. Still effective, but we want you to get both doses because it's now over 90%. And that's in terms of your immunity post-infection. And it's a very complicated thing. And Sarah and I looked at all the research that's available this morning, and we still don't know what actually creates the immunity, because it's a multiple cell response in your system. It's not just antibodies, it's lymphocytes, and it's chemicals called cytokines and other things that actually your body produces to fight off infections if you become exposed to it. So the simple antibody test that people get is not sufficient enough to say whether or not you get immunity. Because it's very complicated. We're also looking to see whether or not how long natural immunity lasts. And I know people are saying, I just rather get the infection because I know it's going to be limited, it's going to be mild. Well, for the elderly, it turns out it's not mild, and people with chronic medical conditions. Unfortunately, all of those folks are vaccinated, or majority in Broomfield and Boulder. And I work in both. It's a pleasure to work in those counties that have done such a good job at vaccinating the most vulnerable populations. So in that in that range of people that have been exposed and unvaccinated in that younger group, we think, and the studies are saying, and they're still watching this because people are still getting infected, that it could range from a month to 4 months and maybe even longer. And in some of the studies that we read, both Sarah and I looked at, and we were both surprised at this, the more severe infection, the longer lasting the immunity. And that probably has to do with revving up your immune system to fight off future infections. And so I don't want to encourage people to get the infection just to get natural immunity. I'd rather have you get the vaccine because it's safer, with only minor side effects. So we're encouraging people to do that. There was another question about what happens if I had the infection in the past? Should I still get vaccinated? And the answer in the research says that you are likely to boost your immune system and last it even longer, maybe 10 to 20 times as much, if you get the vaccine after you've had a natural infection. So those folks, particularly the young people who may have had mild infections, who did well, should probably still get a booster, because it boosts those neutralizing antibodies and those immune cells that we talked about a little bit earlier, that very complicated immune system. It probably is going to help boost, so to speak, your immune system that lasts even longer. And that's been shown so far in the research. But obviously we're learning more and more as we go along. So I'm going to switch to the next slide. So I think this is an important slide to point out that as there are still no vaccine is 100%, and we know that, nor is natural immunity. Remember, we talked about natural immunity or the vaccine is not perfect. So there are still people that are getting the infection, even though they've had the previous infection before, or they've been vaccinated, but are still seeing very few people that have had severe or hospitalizations related to this infection. So it's important to point out that's a good correlation. We still want you to be vaccinated. We still want you to protect yourself, because we're seeing this significant drop in hospitalizations and deaths post-vaccination. So I think I'm going to stop there and then turn it back over to you, Jason, and then we'll have time to answer questions.
Yeah, thanks, Chris. That was extremely helpful. And this will lead into some of the questions, I believe, of what occurs after we go into level clear. And so just a reminder, Broomfield, along with the rest of the Denver metro region, will be moving to level clear after May 16th. And what that means is there's no longer going to be public health orders with capacity restrictions. We will still be providing CDC and other CDPHE guidance on what businesses and events and others can do as far as following public health recommendations. And then if you go to the next slide. Yeah, we're also wanted to just give some updates on the mask order. I know last week that was fairly confusing when we presented it, and I apologize. We had received the order on Sunday, and then we're reviewing it as we were doing this presentation. So our local mask order expired on May 7th. We are currently operating under the state mask order, which expires June 1st. I think the key thing to remember is that masks will still be required in most indoor settings, just because all of the trouble it takes to go through to prove that you've reached that 80% vaccine status, requiring proof of a vaccination status and so forth, could be extremely challenging. So we had examples of what would that mean if you had people walking in and out of a grocery store or walking in and out of a coffee shop or a mall, and how do you track that? I think what we're going to find is for this month, most businesses are going to probably stay away from going through that process because it's so complex. And as I mentioned before, the intent was more for those office-based settings where you have sort of fixed number of people and you know who they are. The other thing, though, is we've discussed it a lot within the city and county of Broomfield and have made a decision just because we have so many visitors under the age of 12 or 11, and also just some of the logistical issues of implementing it, that we're going to continue to require masks indoors for all of our staff and the public in our buildings. And that was a decision made by our city manager's office along with our department heads from operations perspective. And that's how we assume most businesses will go through this process with the mask orders. And then lastly, we'll continue to communicate out to the public on how they can assess risk as they're out and when we move to level clear and visiting certain types of venues or participating in certain types of activities to make informed decisions. What are those higher risk settings versus lower risk? And CDC and others are putting out great information on that, and we expect them to continue to be updated. I think Dr. Fauci just this weekend was mentioning as we start to see more and more people vaccinated across the country, CDC will be evaluating real time what that means for some of their public health guidance and recommendations. And so we'll continue to inform the public as we receive those. And I believe that's our final slide. And so we're happy to open it up to questions. If you want to raise your hand. Councilmember Hinkle.
Thank you, Jason. Thank you for the presentation. Can you guys go back to that last slide a little bit? I just want to kind of point out that it's just going to be really important to communicate. Otherwise, we will have sort of like kind of how we did in the beginning, sort of infighting of, you know, where we have to wear masks, where we don't. I think I like the way that we have proposed sort of that communication level for the risk level, you know, fully vaccinated versus not vaccinated, and different scenarios in which we'll see, you know, masks, and certain scenarios where we won't see masks. It seems like in the state level, though, this is where I kind of run into some issues where, you know, you have 80% of those. Maybe you can re-explain this, but off the top of my head, I believe it is 80% of those who have been vaccinated, as long as you have that scenario. Can you explain a little bit more as far as like the state order goes?
Yeah, and Deb, correct me if I'm wrong, but the way I understand the state order is if within a specific setting, you have 80% of people that have been vaccinated and can show that proof of vaccination, then they can take their masks off. And again, I think, well, I do know the intent of that was not for those settings where you have people coming in and out frequently. It was, I'll use the library, for example, as we discussed this in the city and county of Broomfield, versus an office setting like our public health staffing office, where you have the same number of people that are coming in every day and they may be willing to disclose what their vaccine status is. In those situations, it's two completely different situations because we know who those people are coming in versus the library where you have residents coming in and out continually and you would have to verify that vaccine status. And that's what I think is, again, the intent of this across the entire state. Now, we still might have some businesses that want to go through that process of documenting proof of vaccine status, and that's on the business entity to do that. That's the way the order was written and addressed, and so it would be up to the business if somebody did visit them to be able to show that they could prove that they have assessed and met that definition.
Now, Jason, I would just add that the intention of the statewide mask order really is to protect the most high-risk populations. And so there's a number of settings, long-term care facilities, schools, child care centers, detention centers where across the board, masks are required for anyone age 11 and older. And so so if you set those settings aside, then there's, as Jason was just talking through, I think there are other settings that could be eligible to apply that 80% rule or less than 10, but that really only works well if there's a static population. So, and all of this is in place through June 1st. At this time, we don't know what the plans are at the statewide level to extend that or if it will be further amended. So that's what we're working with over the next few weeks.
Gotcha. Okay. And then I guess my other question is that, you know, I've had some restaurant workers that say, hey, I know I've been vaccinated. And that we are sort of our own static employees. What does that look like for them to be required to be masked still, despite their proof of vaccination? So that's my first question. And then I'll have to remember my second question. I had one more, sorry.
Deb, you want to take it with the restaurant workers, since that's a provision in there?
Yeah, I'm sorry, I didn't speak over you. For restaurants, there was a component of the mask order that called out restaurant workers separately. And so for restaurant workers, the requirement is that 85% or more of the restaurant staff must have proof of vaccination in order to be able to remove masks. So it applies, I guess, a little bit different logic to restaurants since it is a little bit more high risk. They have to achieve a greater rate of vaccination status than that 80%.
Okay, perfect. That's good to know. I did not read that. And then the last part is, I know that childcare has been actually sort of like so the linchpin and everything. You know, we have a lot of people who need to go to work and they're like, well, I can't go to work if my child is in quarantine. So Emmy is now in her second. It's interesting. My oldest son has been in private school all year long, has never been in quarantine. Granted, they have a lot of precautions that they can pay for. I will add that. But my daughter has been back nearly full time for at least a month now, I believe, and has been quarantined twice. So she's actually been in school really half the amount of time. So we see a lot more spread happening in areas where we have public school issues. My issue is that people cannot rely on going to work. So if I were a full-time employee, which I'm hoping to go back teaching full-time next year, or at least part-time, I'm wondering what that might look like for people who are in the workforce and what quarantine might look like in the future as far as schools go. Do we know any, because they actually changed the whole quarantine rules. If you get tested, she got tested on Saturday, and then she could go back to school earlier. So I think the less time that we have to quarantine these kids, I just don't know what that might look like and what that means for people going back to work. And that's my last question.
Yeah, actually, I have two experts, Elaine and Chris, that could talk about the recent release guidance from the state on quarantines. And then I could tell you that those discussions are already starting to occur for what it means over the summer and the fall as we begin to move into next year, because schools have to start planning for that. I could tell you a lot of the discussion amongst the public health directors has been, how do we maintain safety within schools, health and safety, looking at truly that intra-school transmission, and at the same time understanding the disruption that it could potentially cause for learning for students with going out, or childcare for the parent with quarantines. And I think that's part of what we're working through as we evolve in this current iteration of the guidance and the next iteration. So Helene and Chris, I don't know if you guys have anything to add on that.
Go ahead, Helene, I'll let you start.
Hi there, everybody. It's definitely a confusing topic, and we're trying to continue to make it better in terms of just more understandable, as well as just keeping it safe, as Jason said. So I think what we are looking at now and into the summer and summer camp programs is not going to look the same as what we will see in the fall. So I'm hopeful about that. I know that, as you mentioned, there is more information in terms of just being able to test out somebody that's symptomatic or if they've been exposed, and the intent there is to try to reduce the number that are quarantined. So hopefully you will feel like you might see a shift in that. I can appreciate that. That does feel pretty frustrating to, hear that short of a window of time and know that your daughter's been quarantined twice. It is a mix it's a hard call sometimes. And so it's, we are trying to reduce the risk of spread, and we have seen a lot of our cases, about 50% of our cases have been in 29 and younger, and about a quarter of those have been 18 and under. So we know that that's the unvaccinated population, a lot, under that 16 and under group. And so it's kind of multifaceted in terms of that. But I think as we go to 12 and older being vaccinated, we know in the fall, we're hoping even a younger age group potentially vaccinated. All the things are going to help. But I do appreciate the frustration, and I feel for you. And I hope the fall will feel better and look better for everybody.
The only thing I would add, Councilmember Henkel, is that, we're hoping to get the vaccination up higher in our community, so that the less virus in adults means less virus in the children. And so we're still encouraging the schools to do all the prevention strategies that they've done extremely well, which hats off to the schools because they work very hard on this. Where we see, and Helene and our team has talked about this, where we see a lot of this spread is really at home, in unvaccinated households, as well as these extracurricular activities where the guards are let down. And so you as a parent and teachers, as well as other parents, need to really protect their kids from getting the infection, which doesn't bring it back into the school, and therefore less quarantines. So I do think we're probably going to reduce the amount of quarantine in summer and hopefully fall as more people are vaccinated. Because really that's the key, the community spread of the virus.
Yeah, I think that'll help. I feel like our younger kids are really, I feel bad for them because they're the ones who are going to get hit the hardest, and then the parents of those kids for workplace. And my kid can be home alone, although I don't want her to be home alone all day, every day. I mean, she's 12, but she's not an adult yet. So it'll be good to see these vaccines come out for these kids too. Thanks.
Thanks, Councilmember Hinkle. Mayor Pro Tem.
Thank you. I guess I want to go back to the 85% of restaurant workers. So if the company is requiring proof of vaccination in order to go maskless, and I know other people have brought up HIPAA laws before, is it true that really only hospitals can violate HIPAA laws? I mean, is this protected information being vaccinated the same?
So I know we have Nancy on the line, and Pat addressed this last week. And what I understood is, again, the person is self-disclosing this information, and it's also not. Nancy knows the term better than me because Nancy, I'll let you take it from there as far as the business covered entity and the sharing of information.
Right. It's a good question. HIPAA only applies to what's a covered entity, and covered entities are doctors, clinics, could be dentist's office, can be employers to the extent the employer is offering healthcare programs. But for this purpose, a lot of businesses aren't a covered entity where HIPAA applies. And then even if it did apply, then we're getting into the self-disclosure part of HIPAA.
Thank you very much, Nancy. That's all I have. And thank you guys for the update and the good news about the vaccination. I'm looking forward to spreading the word.
Just to add a little bit more to that, I'm sure you guys have talked about it in other weeks, but just the reminder that if someone is vaccinated, then they don't have to necessarily do the quarantine timeline. And so then it's just watching for symptoms. So it is a nice motivation, hopefully, in terms of, people being able to stay at work and or stay at school. And so the more we increase that overall vaccinated population, it will help with all the other things we've already been talking about.
Great point, Helene. Thanks.
Thank you, Helene.
Thanks, Mayor Pro Tem. Councilmember Lim.
I was reading an article that referred to the low rate of prison staffers and the relatively low rate of employees in long-term care facilities who are vaccinated. And it was talking about, giving people incentives in the prison staffing system, and that, I guess we cannot ask our detention staff, we can't force our our own detention staff to be vaccinated. We can't force our own private long-term care facilities to be vaccinated, but do we have some idea if Broomfield's pattern fits what Colorado's is? The statistics are 50% of the prison staffers are vaccinated, 50%, and the long-term care was 65%, which, it seems both of those employees are exposed to populations which, are captive audiences, obviously, and are going to be surrounded by these people that aren't vaccinated. So that's my concern, if you can address it at all.
Definitely, and I can let Helene and Chris address this as well, but I asked this question last week to them because part of it comes down to reporting of vaccine status, and some of that, currently happens in the school setting with other vaccines. Right now, though, all of these vaccines are under the emergency use authorization. They haven't been fully approved by the FDA or authorized. And so that's a limiting factor when you're then mandating, here's the vaccine you need to get in this setting. Because a lot of healthcare settings require, honestly, that people get their flu vaccine. But again, that's something that has been authorized. Regarding where we're at with those two populations, Helene and Chris, do you want to try and tackle that?
Sure, I can add some more. I feel like I can speak more to the long-term care facilities, and that I am happy to say we definitely have higher rates than that. And somewhat of what we kind of expect even with the general public, but we've definitely seen it in the long-term care facilities and some of our other areas is there's a majority of people that are ready to get it right away, but then there's some sector of the population that wants to kind of wait and see. And every week I can tell you that we're helping still set up appointments for long-term care facility staff and residents that are now ready and comfortable to get it. So that number just keeps ticking up, which has been great. And I know that I can't give you an exact number right now, but I feel pretty confident saying ours are well over 80% for our facilities, our multiple different facilities. And we're always still meeting with them once or twice a week. And so we're always a resource to them, and they're both their residents and their staff. So I expect that to kind of go on and people to feel better about it. In terms of in the detention center, I know that percentage probably isn't quite as high. And I know there's been a mix of interest in, kind of waiting for the J&J vaccine, and then just the pause in the J&J put a little bit more pause and hesitation. So I think there's a little bit more of the wait and see in that group, but we're also working with the detention center in terms of getting them set up to have a choice so that inmates, for example, can choose between Moderna or J&J. So that takes a bit more logistics on the behind the scene, but we definitely want people, and whether that's the staff or the inmates, all to feel like that there is that opportunity. So I do think that we're continuing to work on that and kind of chip away at that, hopefully getting that number up higher too. And again, same little tagline with the quarantine, then they don't have to be quarantined and they don't have to be out of work, and all of that still applies to them to, eventually kind of down the road. Right now, it's still restricted with those work groups, but I think as we kind of move into the fall, there'll be more kind of motivation to get vaccinated if there's anyone kind of lingering.
Councilmember Lim, the only thing I have to add is I am as surprised as you are. To me, you would think that the higher risk workers would want to be, particularly obviously you're not you don't have control over all the inmates. And that's a challenge because I know many of the inmates have chosen not to get the vaccine. But you would think that in a long-term care assisted living, it would be higher. And that's true around the state, not so true in Broomfield. So I think providing those incentives, I think most of the workers in the jails or in the incarcerated have taken that wait and see attitude. So I think once we get beyond this wait and see and continue to show that it's effective and get that message out, we're hopefully that those late adopters will eventually get the vaccine, particularly if there's an incentive like, oh boy, I don't have to quarantine if I get vaccinated. So.
Okay, thank you for that. That's it.
Chris, there was one other question that came up last week I was hoping you could address, and it was when the vaccine started to roll out, there was some question around asymptomatic spread versus symptomatic spread. And if you could talk about what it means for the vaccinated individual and then also what it means for the unvaccinated individual from both sides.
Great question, Jason. That study that we referred to on the slides looked at healthcare workers, and it did show a significant prevention of the infection in both asymptomatic as well as symptomatic infection. So we didn't know that data early on. It was just a guess. We knew that it protected hospitalizations, deaths, and severe disease. But now in these retrospective studies, they followed these folks. And that's the challenge with any of these research studies, Jason, is that it's easy to start the clock when you know they got vaccinated and you can follow them with serial testing. It's hard to go back and say, oh, now did you have the infection or when did you get the infection? And so there's not that abilities to follow them long term. So these case control studies basically are what we're being able to measure the effectiveness of these vaccines, both symptomatic and asymptomatic. So it prevents both. So that's a very good thing. I think long term we'll know more, but at least that's that first 6 months of vaccination. I think that's what you're referring to, Jason. Is that correct?
Yeah.
Okay.
Thanks, Chris.
You had also a question earlier on your slides about variants, and I just wanted to comment on that one. You know, it's important, and I know none of us are virologists. Everybody is a budding virologist. But as I read the literature, you know, this virus is like other viruses, and we know this is true about influenza. We know it's not true about measles or hepatitis A or hepatitis B, but this coronavirus and many of the respiratory viruses have a tendency to drift and shift in terms of their mutagenicity or their abilities to change their structure. The worrisome thing, as we've talked about many weeks ago, is that, you know, are they going to be effective, protected against the vaccines? And so far, there's reduced protection, but still effective by the vaccines. Are they going to be able to be tested? Are we going to be able to test them? The answer is yes. Still, we think it's still, our nucleic acid tests are very effective at it. Is the current treatment available that's being used? And that's where it starts to break down a little bit. Now, some of the monoclonal antibody treatments, remember, specific to a specific virus, are less effective, particularly against the Brazilian variant as well as the South African variant. So that's worrisome that monoclonal treatment, but steroids and the remdesivir and the antivirals are effective, and oxygen, of course, is very effective in terms of as you recover yourself. The most worrisome thing is, in my opinion, is the contagiousness of them. And as they mutate, are they more contagious? And that's true of the V117 as well as the South African variant. And looks like, and although it's preliminary, the Indian variant is also looks like it's more infectious. You can see the huge rates of infection, and it looks like there are multiple components of that variant, and not just one type of variant within that group. And remember, there are tens of thousands of these mutations that occur, and the ones we're calling out with numbers and specific sites are the ones that we're watching more closely. So we're about to learn more and more about them. Unfortunately, it was all in hindsight. We still think vaccines are effective, get vaccinated. We still think that wearing masks in closed settings, physical distancing, protecting yourself, long-term care, all of those are still protective. As we begin to open up, then I think we're still very worried about the variants, but our protection strategies in place are very highly effective against them.
Thanks, Chris. That actually helped to add that in. I don't see any additional hands raised from council. So first of all, I wanted to thank Dr. Urbina and Helene for joining us. So they're truly our in-house experts when it comes to all of this, the clinical and medical aspects of this virus, and have been amazing support system. And we will continue to provide updates. I know we're coming before council tomorrow to provide an update. And then as we start to move towards level clear and what that means in our public health guidance, we're working very closely with our communications team on making sure we're getting the right information out to the right people, and that'll continue. So with that, I'll give you guys 10 minutes back in your day. Appreciate it. Have a good one.
Thank you guys so
Thank you,
much.
team.